Hi everyone, I'm just going to share my presentation. I'm sharing it with you now, and I'm also starting the clock now. So, welcome to my talk, Ethical Aspects Around Mass Screening for Celiac Disease, at the annual Celiac Disease Screening Symposium in Denver. My name is Jonas F. Ludvigsson. I'm from Sweden. Uh, I would I would have loved to join you in Denver. I hear it's the only city on earth situated exactly 1 mile above sea level. And I've also heard about your airport, and I love sports, and I know you have several teams in the highest division. So it would have been lovely to be with you. Anyhow, I'm going to talk about screening or the ethical aspects of mass screening for celiac disease. And here's a short overview of my lecture to the left. A background on celiac disease, what is mass screening? What are the ethical frameworks? What are the benefits and harms about consent, equity, and privacy? I'll talk about case finding in mass screening. But I should probably also give a short overview of myself since that will flavor my talk. I am an epidemiologist and I like numbers. I'm also a pediatrician, but I work to a large extent in the wards also with cancer, diabetes, severe infections, neurological disorders, but also in the emergency room. Sweden has one of the highest prevalences of celiac disease in the world. And also of note, I'm the scientific chair of the SCREE-SCOPE study, one of the largest randomized colorectal cancer screening studies in the world, which has influenced my view of screening. So first, what is celiac disease? We need to agree on that for the foundations for screening. It's an autoimmune enteropathy triggered by celiac disease, and it affects about 1% of the Western population. That is actually very important. Usually, we screen for diseases which are either rare but severe or frequent and not so severe. I think celiac disease could qualify into that second category. The symptoms vary. That is also important because it means the disease is sometimes hard to find. Also, of note, there's a treatment, the lifelong gluten-free diet. So if we're going to screen, we have to prevent something. And what we're trying to prevent is probably complications of celiac disease. And we know a lot about symptoms from diagnosed celiac disease, symptomatic celiac disease, but we know much less about complications in asymptomatic disease. Here's an overview from a paper in Nature Review Gastroenterology Hepatology by myself, actually, earlier this year. It shows the potential complications from celiac disease by mechanism. And if you look at some of these complications, like autoimmunity, they may actually be due to shared genetics. That is not something you can impact by a gluten-free diet, as shown in Johan et al.'s paper in Journal of Autoimmunity, 2024. So instead, perhaps this is the picture we should look at. What happens when we get a mucosal healing, when we do not anymore have persistent inflammation in the small intestine? Well, then we see less small intestinal adenocarcinoma, less lymphoma, less hip fracture. But actually, all the blue dots signal those things which are not affected by mucosal healing. And the yellow dots signal things getting worse by mucosal healing. So this is what we're suggesting, what we have to treat those that we screen detect. So what is mass screening? Mass screening is about testing asymptomatic individuals through a population-wide approach. This contrasts with case findings, and examples currently is from Italy and then some US pilot programs, including in Denver, the ASK study. If we look at the WHO criteria for screening, which should be fulfilled before we start mass screening, I would say that most of these criteria are actually fulfilled already, but there are two prominent exceptions. The first one is if undiagnosed and untreated, the disease will lead to severe complications. I'd say we do not know that. The second thing is testing and treatment is cost effective. I'd say there are very varying assumptions about cost effectiveness in celiac disease screening, and I will come back to that. There's an ethical distinction between screening versus case finding. Screening is initiated by institutions, not by individuals. There's a higher ethical threshold to perform screening than case finding because case findings, these people have a reason for being tested for celiac disease. In screening, there's also risk of overdiagnosis and overtreatment. In contrast, I see very few ethical concerns with case findings. At the same time, of course, there are potential benefits of screening. We can detect celiac disease earlier than otherwise. There's a potential prevention of complications. We can have an improved quality of life in some patients, and we'll probably identify people at risk also of other diseases. But there are also potential harms. We will identify false positives and false negatives. That's tricky. We will cause anxiety in those testing positive, stigma in others, and there will be unnecessary biopsies. We will also put an increased burden of gluten-free diet on patients with celiac disease. And this diet actually has some concerns. It may not be nutritionally perfect. Besides, we know the adherence to gluten-free diet is not perfect. Roughly, we usually count on an 80% adherence in celiac disease. I assume it's going to be lower in those asymptomatic and screen-detected cases. They do not have the same motivation to follow gluten-free diet. And if a lower percentage follows a gluten-free diet, it will be less cost effective. It will be less effective to prevent complications or other complaints. We know the gluten-free diet is socially and economically burdensome. Just the other day, I had this conversation with a journalist talking about potential drug treatment in celiac disease, where she pointed out that so many people that she had interviewed with celiac disease complain about the burden of gluten-free diet. Here, we're going to push that burden onto kids who are asymptomatic. I struggle every day about informed consent, usually when it comes to taking a blood sample or having another test in kids. I will have to convince them. Sometimes I will have to go against their will. So there are clearly ethical concerns with kids being screened. Their parents must decide on behalf of their children. There is a risk of coercion, actually, if we implement screening in routine healthcare. I don't think that we physicians should underestimate the authority we have with kids and their parents. We must also be aware that children being screened and their parents have a right to know how ethically relevant, to know what does the screening mean. We have to educate them before we do the screening. And the consent becomes even trickier in adolescence. I'm not saying that we're going to screen particularly adolescents for celiac disease, but it could be relevant for other types of screening, and it could also become relevant in adolescents. But they have a capacity for assent, and there's a risk of ethical tension between parental authority and the autonomy of the teenager. And then on top of that, we have the physician, most often probably taking the side of the parents. And here we have a need for a different age appropriate information. So informed consent and age appropriate information is an ethical issue in celiac disease screening. There's the issue of equity and access. Screening has to be fair. But we already know the screening uptake varies by socioeconomy and education. There's clearly a risk of screening excluding disadvantaged groups. How do we tackle that? How do we tackle that we identify celiac disease, but some parents, some families may not be able to afford the treatment, or that the access of the treatment may vary between different regions in, for instance, the United States. But it is ethically imperative that if we are to screen, screening must be equitably implemented. Can we do that? There's also the question of resource allocation. Screening programs are costly. They include testing, biopsies, follow-up, dietitian support. There's an opportunity cost, an alternative cost. What else could have been funded? And I think there is an ethical need for more cost-effectiveness studies. Actually, the cost effectiveness evidence is, on the whole, not so good. The cost per quality varies widely between studies. The cost of quality per quality depends on assumptions about adherence, quality of life gain, complication risk, and we already know that case finding is more efficient from a cost effectiveness point of view. We will also have false positives, as I have mentioned. And false positives, they'll create unnecessary anxiety and unnecessary procedures, while the false negatives will suffer from delayed diagnosis. Just last week, I had a kid with Down syndrome. He'd been screened, or he'd been screened for celiac disease when he was about 2, 3 years old. His test was negative. He had persistent abdominal problems, and I don't know how many physicians he saw before I took a second blood test on him when he was about 4 or 5, and I know celiac disease. I'm sure his diagnosis was delayed because of the initial screening. The test sensitivity and specificity is not perfect. And screening must minimize, at the same time, screening must minimize misclassification, especially since we deal with people who at the outset are healthy. One way of minimizing misclassification may be to add genetic screening, HLA typing. HLA DQ2, DQ8 testing can pre-select at-risk children. It improves efficiency, but it also raises privacy concerns. It may reveal risk for other autoimmune diseases. So it may be that we give these families a sense that, aha, they already suffer from some kind of autoimmune conditions. They need extra healthcare visits. They don't regard themselves as healthy. They just wait for that autoimmune condition to occur, which is stressful. There's also the data privacy and secondary use of data through screening. Screening generates a large amount of sensitive health and genetic data. Who will have access to this? Is there a risk of misuse by insurers, by employers? Is there a risk that commercial companies will have access to these data? Is that in any way controversial? I think it might be. We don't think that one-off screening is appropriate. Celiac disease can occur early, it can occur slightly later. So with what interval do we run the screening? How often will we do the screening? How many times? But repeated testing increases cost, increases burden, and there's really no consensus at present about the optimal frequency of testing. There's the potential overdiagnosis. Probably we will diagnose quite a few patients with mild or potential celiac disease. What do we do with them? Not every one of them will progress to March 2 or 3. So there's a risk of unnecessary treatment. And how will people be affected by a gluten-free diet if they do not have celiac disease? Well, we know some things. We know that from the paper by Ben Level and et al. In the BMJ in 2017, that consuming a gluten-free diet increases your risk of coronary heart disease. So you're not gaining from following a gluten-free diet unless you have celiac disease. There's also the psychological labeling of healthy children having a diagnosis for which they will be followed for many years. There are commercial interests pushing screening, diagnostic companies, gluten-free diet industry, and here's a potential conflict of interest. How do we tackle that? So there's clearly a need for transparency and regulation, both in the industry, but also among us researchers, before we have an opinion on screening. So many stakeholders are involved in celiac disease screening: children and families, healthcare providers, policymakers, commercial entities, and researchers. I sometimes sense that researchers focusing on one disease are very much focused on that disease. I just talked to an ADHD researcher who said they finish every paper they write by suggesting that the population should be screened for ADHD. I have this friend who does research on prostate cancer, says every man should be screened for prostate cancer, including with an MRI. I tell him, but if you occupy all the MRIs, when am I going to do my MRI for suspected brain tumors in kids? So the alternative is case finding. Case finding targets high risk or symptomatic individuals. It's more cost effective. There are fewer ethical concerns, but we will miss cases. So if we compare mass screening with case finding, we can say mass screening, it has a broader reach. Case finding is targeted. The costs are higher in mass screening. Case finding, lower cost. The benefits are low in mass screening, and I'd say higher among those identified with case finding. The ethical risks are higher in mass screening, lower in case finding. But another very important point is the cost effectiveness. The earlier evidence shows very varying amounts or cost per quality adjusted life years. A Swedish study, which is most relevant to me and which is perhaps the one I trust most, trying to screen 12-year-old children. They calculated a quality of adjusted life years of 40,000 US dollars, but they assumed a very high gluten-free diet adherence. I don't think the gluten-free diet adherence is that high, not even in Sweden. So assuming it's 80% rather than 100%, the cost would rather be 50,000 quality US dollars. Young adults being screened in Italy, similarly, assuming a super high gluten-free diet, which is quite unreasonable, but they landed at 49,000 US dollars. And then we have a study from the Netherlands reporting completely different numbers. But I want to say that one, they have their population consisted of people with symptoms, which is different from the usual mass screening. Second, the costs they present in the papers are much lower than what anything I've ever seen before, like including testing, including staff time, would be 25 US dollars or 25 euros per patient, which is an extremely low cost. And besides, they make different assumptions. The one with the best assumptions showed a cost of almost 4,000 per quality, but a different one showed a cost of about 10,000 US dollars. So I'm assuming 40,000 US dollars per patient. And here's just, I'm trying to model some US data here, assuming we have a 1% prevalence of celiac disease in the population, that in those with TTG above 10 times the upper normal, we just run a second TTG, no biopsy. But among the other ones, we run a biopsy. I'm assuming an adherence of gluten-free diet of 80%. I'm assuming that undiagnosed celiac disease is associated with anemia, reduced well-being, fractures. And here are the costs I've just Googled and that I assume. Okay. In the US, we have about 3.6 million births per year. If they were tested twice per life, and we'd say 80% of the population would say we want to have screening. And I'm finally assuming in a routine healthcare setting, no researchers involved, just routine healthcare, a sensitivity of 93%, specificity of 98%. Then, of 5.76 million kids tested every year, we would have about 53,000 positives. Also have some false positives. If we sum up this, the cost for this screening program in the US would be $500 million US dollars. The question is then, what can we do otherwise with $500,000 US dollars? Well, we can run about 20 million FIT tests for colorectal cancer. Or we can close gaps in routine immunizations, millions of doses, setting up mobile vaccination clinics. Vaccines usually have a quality cost of less than 5,000 US dollars instead of 50,000. We can vaccinate about 15 to 20 million US kids against influenza. We can reduce hospital costs, complications, mortality, and the quality here is less than 10,000 US dollars for influenza vaccinations. We can implement screening programs for lead poisoning to prevent irreversible neurodevelopmental harm. This could have huge impact on cognitive health in kids in the US. We could do mental health screening in children, ADHD, depression, anxiety. We could actually, for $500 million US dollars, train thousands of school counselors and that would be good for therapy for hundreds of thousands of kids with mental health problems in the US. Or we can screen all kids in the US for celiac disease. So what are my ethical recommendations for mass screening? Well, I think we should avoid a premature implementation. I think we should ensure informed consent. I think we should address equity and access and monitor outcomes and harms. And my take-home message from this talk is that celiac disease is common and treatable. It is important. I did not write more than 300 papers about celiac disease because I consider it to be trivial. But mass screening does raise ethical concerns. The benefits for asymptomatic children aren't clear. I think case finding remains preferable. and ongoing research is essential. And if I'm going to list some research gaps that I think have to be filled before we implement mouse screening, we need to know more about the natural history of asymptomatic celiac disease. We need more data on long-term outcomes of early diagnosis. We need cost effectiveness in real-world settings. And we need to know more about psychosocial impact of diagnosis. And before we start screening, I think we should consider what resources we have, and we should ask ourselves the questions, do we do the right thing for the right reason when we screen? And with this, I want to thank you for listening. Please get in touch if you have any questions. Here are my details from the KI Institute, Karolinska Institute, and my email address. And below to the left, you have my LinkedIn profile. Thank you very much for listening.